Good morning, gentlemen. We will be discussing about the predictors of failure of non-operative treatment of rotator cuff disease. In other words, when do we stop conservative and start our surgical management? I'll be presenting this talk on behalf of Dr. Atul Mishra. I'm Dr. Vishal Agrawal. 10 out of 1,000 patients which we see in our clinic are of shoulder pain. Of that, 74% have signs of impingement and 85 almost have a painful or a torn rotator cuff. Incidence of rotator cuff disease or dysfunction increases with age. More than half are over the age of 60 years. Tempelhoff also demonstrated that rotator cuff tears also increase with the age. Now the significant point is that more than half of them who are asymptomatic become symptomatic within 3 years and also progress in size during this interval. If we go to the pathogenesis, the cause of the disease as far back as 1939, Codman hypothesized a theory in which there was intrinsic degeneration of this tendon, supraspinatus. You could see in the MRI picture also there is an altered linear signal intensity change in the supraspinatus tendon. Later on, the external factors like subacromial spurs or change in the CA ligaments, osteophytes, calcific tendinitis or subacromial bursitis came upon. The recent trend is a combination of both repetitive microtrauma and age-related degeneration, which causes rotator cuff disease. Needs describe 3 stages of this disease, in which stage 1, less than 25 years, we have edema or hemorrhage of tendon or bursa. In stage 2, 25 to 40 years, we can have inflammation of the tendon and fibrosis, and more than 40 years, we generally have a tear. If we go to the natural history of partial thickness tears, almost 10% heal on their own, 10% become small, 53%, more than half, propagate and progress to a large tear, and around 28% become full thickness tear. So that's about the partial thickness tear. A full thickness tear do not heal spontaneously and may progress with time and go upon to develop a secondary osteoarthritis. Now about the management, how to decide? There are some deciding factors which would be highlighted. Is the shoulder stiff? If it is, do not operate. First, it has to be mobile. Then only there is any point operating and making it a repair, making the tear repair. Is there an impingement? It has to be looked upon. Is there a scope of rehab after we repair it? And is the cuff so much damaged that it is appropriate for the surgery? Simple radiograph, a simple AP view. Besides that, a 30-degree caudally angled AP view, which will be effective in showing us the subacromial space, maybe a bursa, maybe a spur or a calcific deposit. As we can see in this radiograph, calcific deposit here and a spur here. Accuracy of ultrasound is quite good, 87% in diagnosing partial and full thickness, but MRI takes precedence only when it shows retraction or associated fatty infiltration in the muscle belly. Subacromial bursitis, the mainstay would be non-steroidal anti-inflammatory drugs and rotator cuff strengthening exercises. Short-term use is benefited, less than 4 weeks. Physiotherapy does have a role. A satisfactory result has been shown in 63% patient in quite a big number of studies. Subacromial steroid injections can be given, should be given for improvement of pain and range of motion, and also aids in rehab. But it is important that the injection is given in the correct site. A significant number can be of incorrect injections were given, almost 23% for posterior approach and 31% from the anteromedial. Injection in the subacromial space alone showed a significant decrease in pain. If the patient's symptoms fail to improve, it doesn't mean that repetitive injection cannot be given. They can be given. Even in established cuff tears, there is still a role of conservative management. Evidence for conservative management of rotator cuff tear dictates an initial period of at least 6 weeks to 3 months, unless there is evidence of acute tear in young patients. But a prolonged conservative treatment have negative roles like muscle atrophy, increase in the tear size, fatty infiltration, tear retraction, and so a diminished outcome. At the end of 2 to 3 months, if the symptoms don't improve, we should go ahead and do a repeat ultrasound or an MRI. Bartolozzi in the study 136 patients managed conservatively with symptomatic rotator cuff tears identified the following factors which were associated with worse outcomes: full thickness tear more than 1 centimeter square, symptoms persisting for more than a year, functional impairment and weakness. In a large study by Samuelson, conservative management of full thickness tears have a poor outcome, almost 40%. Now the guiding principles also depend on the etiology. If we have a bursitis and impingement, conservative trial of 3 months is indicated. If not responding, identification of the cause like osteophyte spur or a downward sloping acromion should be identified, and then a plan for surgery should be made. Indication for surgery would be a failure of a conservative management, deterioration of the symptoms more than 3 months, MRI or a USG evidence of increasing in the tear size or retraction, a fatty infiltration, or a clinical finding of weakness, decreased range of motion. Lastly, a traumatic tear is a direct indication for surgery. Early repair of the tear will definitely prevent progression of the tear and a complication of tendon rupture after the surgery. Even if the tear has progressed to massive tear with retraction, repair it, and it will prevent radiographic deterioration and cuff arthropathy. Thank you.
Any questions?
Yes.
Surgeon.
Just use mine. Here. So, lovely. Very nice. This is 98% of what I do in the office every day. Just one point. I strongly, absolutely disagree with you when you say that, as I understood, there is a role of conservative management in full thickness rotator cuff tears. Because there are many studies, and a beautiful one done by Mark Franco from Miami, United States, in which he proves that when you don't have minimal remaining attachment from the tendon to the greater porosity to the footprint, there is absolutely no biological environment for healing. So this is why I always tell my patients, if you have a partial tear, we will try conservative management. Obviously, if the tear is 99% in the MRI, I'm going to fix it arthroscopically. But if it's more or less 50, I'm going to try physiotherapy, injection, and so on. But once the tear is a full thickness 5 millimeters or 5 centimeters, there is no biological environment for healing, and so there is an absolute indication for surgery. I would like to know if you agree with me or not, and especially for offer. What do you think about what I just said?
Yeah, I agree. If it's a traumatic tear and a full thickness one, we should directly go ahead. But if it's associated with any other disease like bursitis, or it's a degenerative tear, full thickness, we might try a conservative management before the range of motion is there.
So you think that in a full thickness degenerative rotator cuff tear, there is space for conservative management?
Yeah, few weeks, yeah, definitely.
I disagree, and many papers say that the more you wait, the more you will have retraction, fatty degeneration, fatty infiltration, poor tendon quality, and the worse it will be your repair, and you will have to do in a year whatever you see, medialization of the footprint, posterior interval slide, anterior interval slide, and a lot of medical things like we say to make the tendon heal. And if you had this surgery previously, it's so easy. So I disagree with you. I would like to know what other things.
I think again it depends on the patient, and you have to make up your mind beforehand. So if you have an elderly guy, 85 years old, or lady, very sedentary, very frail, and you decide, well, I'd like to do the most not to operate on her, then you take the decision.
Even because of the clinical comorbidities.
Yeah, then you take the decision, okay, I'm going on the conservative path, that's fine. But you've made an educated, decision that you don't want to operate anymore.
Yeah, but if the patient is 55
no,
or
wait.
less.
If it's a young patient, I will tend to, not to mess about. I mean, if I gave him one injection and he's pain-free and he's fine with that, that's fine. But I will tend to be more aggressive, like Sergio, and try to repair it beforehand, because I believe in anatomy and believe in restoration of anatomy. And if I repair it now, which can be easier with better biological, conditions, then I prefer to repair it now rather to wait until it deteriorates to a massive tear, fatty atrophy, and then it will not work. So I would not mess about with too much conservative treatment. If there's a partial tear, I may consider giving one injection and see what's going on. If he's got a full thickness tear, he's got night pain, I would not even try an injection. I will try to persuade him to go for surgery. If it's a young patient, if it's a active patient, and age is not in my view, it's not a chronological age; it's a biological age.
Yes, this is my last comment. In my country, I'm seeing many patients with 65, even 70, playing tennis. So if he comes to me,
Sergio, 65 is young.
Okay, okay.
Everyone is 10 years older than me is young.
Okay, I understand. But you see, a patient with 70 years playing tennis, with a 5 millimeter full thickness tear, I've got to fix it.
No, but
I cannot lose the chance. Yeah.
No. Sergio, I completely endorse what you said, and we must be. In this country, they may not be tennis players. We're not a very sporting country, but we need the shoulders.
Sure.
As it is, the average time for patient to reach us is late. So by the time they come, we get too many muscle tears, too many wastings. If we delay and this thing, it's just going to make our job much more difficult.
If we
delay or avoid surgery,
if you wait,
I don't see any reason why to avoid surgery in a full thickness tear up to 70.
Sure, 65,
No doubt.
70.
No doubt.
Sure.
After 70 to 75, you decide on the physiological age.
On the
If he's
patient,
fit,
yeah.
On the
if he's
patient.
fit, he wants to do all the stuff that Sergio kind of does, then we will operate him.
Sure.
If he's happy to accept a disability and modify his lifestyle, then I don't contest that.
Sure.
The only controversy I see, I don't classify tears as degenerative and traumatic. It's irrelevant. Because
It's
even
not
if
irrelevant. It's not irrelevant. Traumatic, you must repair.
No. All tears are degenerative. The trauma actually speeds up the degenerative tear. That's
Okay,
the only
sure.
difference. The only controversy I see is somebody who comes up with a asymptomatic shoulder and has a full thickness tear. Then it's difficult. Then that decision making is difficult because he's going to manage as per the study by Frankel, and at some point he'll go down once the proximal migration occurs. But that's the only patient I would continue conservatively.
And I would just make a final comment. Asymptomatic full thickness rotator cuff tears is an issue that is still not understood.
Yes.
This I learned in San Diego many years ago. So there are papers saying that we cannot understand why a patient has a 4 centimeter tear and he's painless. But in these cases, maybe we are, as he's painless, we are trying to operate maybe the MRI and not another patient.
Yeah.
But this is an exception. Yeah.
Absolutely.
98% of the tears
Absolutely.
will have pain and symptoms.
Yeah.
Okay.
Thank you.
So is that true that 98% of the tears would have symptoms?
99.
Because
Oh, yes.
one would
Where is my
Neck
number sheet? Huh?
pain, they present with tennis elbow, it may not be shoulder pain all right. But you ask them, are you lifting the bag from your back of the car? They say, I can't do that.
Yeah.
Then they come back with pain on the opposite shoulder because they're overusing the opposite
Yes.
shoulder, especially if the opposite shoulder is the dominant shoulder.
Sure.
Thank you, Dr. Shoulder8.
I just want to say, I don't think it's 90%. Those who come to us with a cuff tear, it means that they are not in, they lost the balance. They're now on downhill, and we need to repair them.
Who's next?
For discussion, can I invite Dr. Prathamesh Jain to give his next talk? The talk is on massive cuff tears, options and outcomes. Determinants for various management strategies for the difficult problem. Recent advances.
Yeah. I'm basically presenting this talk with an aim of making our surgeons bolder and to address more and more massive contracted rotator cuff tears. This topic came to my mind because I am working in a joint replacement center, and I got a lot of patients who have been advised reverse shoulder replacements for massive cuff tears, who have no arthropathy, just massive cuff tears, and they have been advised reverse shoulder replacement. So this is some of the tears. Definition wise, they are large tears, 3 to 5 centimeters in 2 or more planes, and we usually classify massive irreparable tear as more than 5 centimeters in the dimensions. So they are traditionally avoided by the surgeons for the fear of poor results and inability to secure a tension-free repair, and offering of reverse shoulder replacement in these cases more and more because of involvement of industry. So Burkhardt opined that even an incomplete repair in such massive tears will lead to a acceptable outcome and should be attempted, and we should not even be afraid of not operating a patient who have a fatty degeneration, because in spite of fatty degeneration there is an adequate chance of repair. So if your job is technically sound, in spite of you doing an incomplete repair even in a fatty degeneration patient, the patient will be happy. So the tips of trade in these cases is, first is middleization of the footprint. You should do significant superior and inferior capsular releases to release the adhesions. You should be aware of the margin convergence techniques, and you should be aware of the recent techniques of anterior interval slide and the posterior interval slide. You can do anterior interval slide either in continuity or without continuity as per your wish. Interval slide was initially described by Toro. It was emphasized by Burkhardt thereon. An anterior interval slide classically includes the release of coracohumeral ligament as well as the tissue on the anterior aspect of supraspinatus, and the posterior interval slide actually includes the release of supraspinatus and the infraspinatus tendon in between the insertions into the respective tendons, and both these procedures can actually increase the excursion of the tendon by up to 3 centimeters. So this was one of my initial cases, and I realized that if you do a tension repair in your massive cuff tears, you actually can have pull out of your sutures, and it's very important to achieve a tension-free repair. This is the post-op of the same patient. So this is what we do. Initially we started with the lateral portal viewing technique, and we see this is an old video about 3 to 4 years back, and the first step we have to do is identify the excursion of the cuff, which in this case was small. Then you pass a traction suture, one traction suture in supraspinatus and the other a traction suture in infraspinatus. You identify the scapular spine. So this is the traction suture that we are passing. So we pass one traction suture for the infraspinatus part. We usually do it with a high posterior middle portal, and one traction suture in the supraspinatus, which we can pass through either through a Nevasia or your standard expressive techniques. Initially I was tending to do it with the lateral portal. It was a bit confusing, so I then modified my technique and started viewing the same through the posterior portal. I identify the scapular spine. This is the rotator cuff tear. Identify the scapular spine, mark the interval between the supraspinatus and the infraspinatus with the electrocautery probe, and then pass the sutures on the posterior side, that is the infraspinatus, and on the superior side, that is the so this is a traction suture which is passed through the infraspinatus tendon. This is a traction suture which is passed through the supraspinatus tendon. We pull both the traction sutures so as to delineate the interval between the supraspinatus and the infraspinatus. The interval we have already marked, and the next step will be to cut this interval in this plane up to the tip of the scapular spine. So when you pull it, and then you can use your arthroscopic scissors to actually release the tendon from this point up to the scapular spine. At that point of the scapular spine, you should be a little worried about the nerve, so you should point your scissors upwards. And as soon as you do this release, you will find that your excursion, as soon as you release this, reach up to the scapular spine, you will find your excursion will increase up to 3 to 4 centimeters. And then you will be able to achieve a tension-free repair. So this is a supraspinatus belly, which is now much more mobile. And as far as the infraspinatus, you see, the infraspinatus is much more mobile, and it is reaching up to the tuberosity. And in these cases, you can even do a traditional double row repair if you wish. So this was the initial X-ray, and the patient presented with a proximal migration, reduced interval, and he was being advised reverse shoulder replacement for this case. But we attempted it, and we could ideally do a good double row fixation. 1 anchor, 2 anchors for supraspinatus, 2 for the infraspinatus.
Question: Did this X-ray? How long after this surgery? 1 year, 6 months?
Oh, this is 6 months old.
Okay, because you see that the humeroacromial space is now much better.
Better,
So
yeah.
the cuff is working
Yeah,
here.
yeah. So this is actually sometimes these tears can be associated with the subscapular tears, and you should fix these. As far as the interval slide is concerned, my average age was about 70 years, so these are usually older patients. Most of them have biceps rupture, tenotomy or tenodesis. You can decide. Older patients, I usually do a tenotomy. In some patients, I was not able to obtain a good repair with supraspinatus, but even if you repair only infraspinatus, it is much better than doing nothing. This is one of the patients, old lady, 1 year follow-up, smiling. So in conclusion, don't be afraid of massive tears. Be technical sound and just be bold and face this tear, aware of all possible techniques. Keep posterior interval slide in your armamentarium. Trust me, if you use these techniques, most of your tears can be fixed. And reserve the reverse shoulder arthroplasty for arthropathy. And realize even an incomplete repair will be rewarding as far as the patient is concerned. Thank you.
Yes, please.
I would like to.
Ashish was first.
Prathamesh, I used to be very excited about interval slides 4 years back and used to struggle and pick up and things. Pretty much outdated now, we don't do them because we're changing anatomy. The recruitment of muscle may not happen. The consistency of results with large tears or medium tears is very good. The retear rate is hardly any. But with massive tears, this result is seen, but it is not consistent. You can't guarantee the patient, number one. Number two, the retear rate is also very high. So when a patient is around 70, then I'm not going to get excited about this. When I have a patient who's 50 and 55 with a massive tear, and we see a lot of that in India, then I am compelled to do this, and I completely endorse this approach. You have a 65-year-old with such a big retear, such a big tear, and then you're struggling to clutch. And if the tangent sign looks positive, there's gluteal free, I will not do a massive repair because you can achieve it. I can't guarantee the patient that he'll reach that stair, number one. Instead, the reverse is a much more predictable option in those patients because you don't want a resurgery on them because they can retear within. I've had retears in 1.5 years, 2 years, and then it's very difficult to explain to them, and then they are kind of reluctant. But I completely take your point. Somebody who's, so I would take two factors very important to decide that. One is young age, 50 with a massive tear, definitely do this. Somebody who has no major wasting, so gluteal 1 and tangent sign just about negative or just below the tangent, still do this. But you have a 50% wasting there, there's a lot of infiltration. So let's not confuse the wasting and infiltration. Two different independent, both are bad. Very reluctant.
Just one more practical comment. I completely understand and agree with what she said, but last year, 2012, we have Brazilian Congress of Shoulder Elbow every 2 years. So last year we had a big fight, a big crossfire, exactly about this point, whether to operate or not. Massive tears are after 70 years old. There is a guy that Offer knows very much, that one of the best guys of shoulder arthroscopy in Brazil, Dr. Gleison Coutinho. He's very famous, and he's a huge defender of the idea of giving a chance to these patients after 70, and he showed a case last year of an 85-year-old, very active patient who had a similar case and had a very reasonable clinical result in spite of fatty degeneration, anterior superior scape, and so on. And we had a big fight, so I understand that you must, it's a question of philosophy, of if you accept to give these patients a chance, because I know that the results with a reverse are much more predictable, no doubt, but the surgery is much bigger. It's 4 holes against a big surgery, a big cut, a chance of infection, and we know that the complications of reversing in inexperienced hands are huge. So I think that I too agree that I must explain to the patient and to the family, well, the chances of a repair are big, the results are much less predictable than a repair in a less than 55-year-old patient. But if there is something in the MRI, I think that you should give it a chance, because it's much less. The surgery has much less morbidity. So maybe this is what Dr. Anders Eklund from Sweden, Stockholm, he says. If the other side is good, and if the affected side is very bad and it gets reasonable, the patient will be happy. So this is the old phrase: if the patient is happy, I am happy. Even with a reasonable, especially if the other side is still working in a nice way.
There is
It's philosophical.
I would say that, you know, as the rabbi said, you're right and you're right, but his wife said, how come both of them are right and you're right too? But the thing is again to adjust it to the patient, because again, I agree with my friend Gleison and with my friend Steve Burkhardt that fatty atrophy for me, or fatty degeneration for me, is not an issue. I will repair them even if they have the Gutelier 4, because I can make them better. What I will tell the patients that I may not guarantee they will get the strength back, but they'll get better function and pain relief. Now, it's a philosophical question, because if I have an active young patient, I would like to give him the chance of doing the repair and maybe gaining some time before I have to do a reverse shoulder. If it's an elderly patient, it's a different question, because if you take an 80 years old lady or gentleman and you take him through a rotator cuff repair to a massive cuff tear repair, you keep him in a sling for 6 weeks. He is struggling to cope with these 6 weeks. Then, if for 6 months he struggles until he gets a good function, and then it fails, that's a major problem. On the other hand, if you take someone like that and you do a reverse shoulder, he straight away, within 2 or 3 months, is up and running. Now, this is something you have to discuss with the patient, because some patients will say, no, I would like to have the small operation, and if it fails, then we can do that. And you have to be clear with yourself. If you think, let's say, if I have a patient that I did a cuff repair 5 years ago, and he comes back now, and I look at my note and I said, I struggled with this calf repair. It was a massive tear that I had to pull and push and all that. There's no point of doing a second one, then I'll go for a reverse. But if it was a small tear that I repaired and now it's a bit larger, so well, let's have a chance and do it. So it's not, there's no one, school answer for everything.
There is no right and wrong.
No, but I mean, you have to bear in mind then that it's a smaller operation, and it's better to do a smaller operation that you have a fallback to do something else rather than to do something that you don't have much fallback. B, if you have a patient that is, is old and you want to give him one good operation and that's it. So.
Well, it's not that said. The reiterates, if you look at Buddy Savoy's review in OCNA on the massive tears, the reiterate is very high.
It's high.
That's why we must take into factor, we counsel all our patients, and the ones in India, it's not an insurance-driven market, so patients can't afford a reverse. So when they say that there's no way I'm going to afford a 3 lakh rupee operation, then we say it's okay, I will do it, but there are limitations, mind you. If somebody is young, there is no contest. We must make every effort to come in there. But when it's 70, then there is no problem.
See, I personally, I'm very ambitious and I want to repair all of them. And sometimes you have to stop and say, listen, I'll do a reverse, will be much better. Get you up and running, then I'll do another attempt to repair your calf tear. But that's where this line cross, it's different for each patient.
There's a lot of gray area.
Yeah.
What's the youngest age in such massive irreparable calf tears you would like to do reverse? Young age.
What's the youngest that I've done, or the youngest that I would like to do? My youngest patient, I think, is 64.
64?
Yeah.
And
It's a lady, I can show you this lady later on. It's a lady that I've done 2 attempts for calf repair.
Okay.
And both of them failed. She had ultra superior scale. She was miserable, and the only. But the advantage is I'm doing the Verso, which is a stemless reverse. I'll show you later. And again, all the options are still open for the future.
Okay. And what would you tell that patient that how long this reverse shoulder would last?
Well, when I did it, I told her probably that it would
10
last.
years.
No, when I did it, I told her that I know it lasted about 4 years because I had only 4 years of experience with this implant. But I don't know, when we started with the Copeland, again, we didn't know how long it would last. Now it's 27 years, so,
This issue was debated at the ANSI course this year heavily. And Christian Gerber, who's kind of the devil's advocate all the time, was on the stage. And so still last year, we were like, don't do it before 65, don't do the reverse before 65. But now we are getting 15 years reviews, and the current crop of reverse shoulders are far superior. We used to be full of lack of confidence of putting a reverse in the glenoid because the glenoid is so small.
Sure.
But the kind of reverse we are getting now.
Yes,
the
but we have-
glenoid is not a problem now. The problem is on the dislocation side.
You are talking like a hip surgeon. Because the hip surgeons now, they say, oh, this guy has AVN, he studied because he had a lot of corticoids, so I am going to do a stemless prosthesis, and this is going to last about
I'm not pushing
25.
this. I'm just reflecting Christian Gerber. Christian is a very conservative guy.
Sure, and a wonderful.
Yeah.
surgeon.
So, and he's well researched. He said there was an eminent panel of top shoulder surgeons in the world.
Yeah.
He said, what is stopping you from putting a reverse in a 50-year-old who's absolutely dropped arm, failed 2 rotator cuff repair surgeries, and nobody could answer it.
Okay.
Nobody could answer
Well,
it.
I tell you what stops
Not
me.
even
What-
himself.
what-
Not even himself.
But
what-
they didn't agree to it.
Okay.
But now the question has started rolling now.
I'll
Okay,
tell you
good.
what stops. What stops is it depends on what type of prosthesis you're using, because if you're using a stem prosthesis and you have to remove it or replace it after 15
You don't need
years.
to. These are all modular prostheses now. So the stem remains in place.
Wait to my talk, and this modular thing is a gimmick, it doesn't work in real life. Trust me, I'm revising a lot of prostheses from all the way around. And that it's a nice gimmick that the companies are pushing, this convertible,
this is
because
the Exatec, huh? The
Yeah.
Exatec.
No.
the
Yes,
Exatec or any other company,
No,
it's a
not
trend
Exatec,
now.
not this.
Now the problem with this prosthesis is that it's a gimmick. that was taken by the companies, and taken by a lot of surgeons, because it's only as good as the first surgeon has put it in. Because if the first surgeon put it in the wrong position, the wrong height, the wrong version, then you have to take the whole damn thing out.
That holds true
Okay.
for any prosthesis.
No, because if you have a stemless prosthesis, you still have the whole bone there. So you don't have to take the whole thing. To remove a well-fixed stem prosthesis from the humerus, it's a nightmare. Trust me.
And it's a nightmare. Huh?
It's a nightmare.
It's a nightmare.
It's a short operation, about 6 or 7 hours, and you end up with a pieces of bone that you have to fix with a wire, with a cerclage wire afterwards. You have to keep the patient immobilized because you have to do a lot of bone graft and all that.
And pray.
And pray, and it doesn't work. It doesn't work. No matter which God you pray to. And it's a disaster. Now, this convertible thing is a great idea on paper, but if the first surgeon put it wrong, you still have to take it out. And the other thing is, the cut, the humeral cut, is different for anatomic shoulder and for reverse shoulder. So you have to have.
We can probably address this.
We do it on the, yeah.
We're going to do
Okay,
it.
we'll do it on.
Just, Ashish, just only one thing. In Indian scenario, what do you think is the lowest case? I think first patient for me was 59. But
We've done at least 3 for 60, but they are like completely dropped arm, and they were fracture cases who've
I think
just
Western
had
is
no
slightly
function.
different. Our Indian scenario,
Yeah.
we see patients who are of like.
But our Indian patients are physiologically 10 years older
Yes.
than the European patients anyway, life expectancy wise and physically also. So
We can discuss that on the arthroplasty.
Yeah.
We go-
Just in this experience, most of the patients whom I discussed, they opted for a rotator cuff repair as compared to repair. 6 to 7 patients. Okay, thank you. I discussed with them, yeah.
In India, so
Yeah, I discussed with them thoroughly, both them. Most of them opted for a rotator cuff repair.
And final results?
Good,
Good?
good.
Good.
Thank you. Thank you.
Partial. Well, I can actually talk on. I'll give you a short video because I didn't find my talk about this, but just repairs instead of that. Okay, someone else is.
this talk is going to be about partial cuff.
Yeah. It's I was just asked a few minutes ago by Amit to do that, so I couldn't find the talk, but I found a video that. That's just to a slide to show you where I'm coming from. I'm coming from Reading, which is the big town next to the small village called London. And so. Okay, this is a quite an old video, but this is a partial thickness tear, joint side partial thickness tear. You can see the biceps here. This is the insertion. This is the area of the tear. Looking from the joint, from the posterior portal. Now I'll put a needle in. I don't know if in this video there's a needle, but with a needle I'll find where my best portal will be on the skin. Yeah, and then put the knife and open in line of the fibers. So I'm doing the trans tendon. I try to preserve the remaining tendon there. In my concept, why to destroy something that is there already connected and give good alignment for the new fibers of the healing process to take place. So in line with that, then I take the shaver. Oops. Yeah. Trim a little bit the fibrillations and then prepare the footprint. On the bone to have a little bit of reactivity. I don't want to take the whole cortical bone. I just want to have a little bit of reactivity there. And again, technically, you play with your camera. Your camera is your neck. You turn the camera left and right to see the best of now I want to see the area, so my camera is turned to the left. Okay, now finding where I want to put the anchor. This is quite an old video, I think, so it's an old anchor. Oops, come on. But it doesn't matter which anchor you use. I prefer to use the new biocomposite anchors, as was presented yesterday. They dissolve completely, become bone. We hope so. Okay. So you can see from the anchor, it's an old video. But the technique is the same. I use what I call is the parachute technique, where I will do 2 mattress sutures, one in the front, because it's a C-shaped tear. Actually, one in the front of the C, one in the back of the C, and then I'll tie one to another over the top. So actually now I'll take a manipulator and prepare one of the sutures to the back towards me. Oops. Prepare one of the sutures towards me. Yeah. My computer is playing up. Okay. And then actually going through the cuff, the tendon, yeah, and pulling doing a 2 mattress, 1 mattress at the back, 1 mattress in the front. I use the sixters to go from, I don't know what's going on here. I'm using the sixters going back and forth for some reason. I'm using the sixters, you'll see here, using the sixter from blind from the, oh come on, blind from the bursa, and coming in, decide where I want to come, and I want to be beyond the cable, coming with a sixter in, and grab the suture and come out. That's the second one. And then going on up to the bursa after I've done the 4, going up to the bursa and taking the sutures, each couple of sutures together, make sure that there's no interposition of soft tissue in between, and take the whole 4, after tying them, take the whole 4 from one portal. I take it from the most medial portal, and then I tie one of the purple ones to one of the blue ones. Actually, this is I'm still tying the first mattress. Sorry about the quality. This is old video and a bit pixelated. What's going on here?
Play.
No, that's it. Okay. Anyway, what I do is I tie. Let me just get in here. I'll show you. The idea of the parachute is this one.
Okay.
That there's one anchor. There's one mattress here, one mattress there, and then I tie over the top one to another, and this gives a good apposition, actually a good, all this surface area is good, you get good apposition to
It's
the,
called the takedown. You take down the tendon.
yeah. And let me just, you can see it here. This is the parachute technique, and you can see it how nicely it creates a good apposition of the whole tendon down. Okay, and it's all done trans tendon. Sorry, that's yeah.
Two issues. One is when are you going to decide to repair? Is it just a symptomatic
Oh, yeah.
clinic report, or how do you assess basically that it's more than 50, or what are your percentages?
Yeah, I mean, we still don't know, to be honest, what to repair and what not to repair, because up until recent years we were comparing oranges and apples, and nobody knew what to do. So if it's we're using in the recent years using the Habermeyer classification, because he classifies it to the depth and the extent of the tear.
How do you assess that depth? I mean,
By MRI or by ultrasound?
Arthroscopically.
yeah. So how? I mean, artistically, how accurate could you be with the?
You can be quite accurate, because you see if there's you can actually differentiate between minimal scuffing, which you don't need to do anything, you just have to note it, because this might progress later on, but just to note it. You
After
have
that, you can palpate from the dorsal side with the probe the tendon, and then if you feel it in a different way,
you can see that this
Of course, move.
is actually, if you touch it, it
yeah,
moves
it's a sign
very.
of
there's-
tendon fragility.
Yeah. So I mean, first of all, you can see the amount of footprint that is actually bare. Okay. So you know the tendon, normal tendon, is about a centimeter, about 10 millimeters. So anything that will be more than, I would say, 4 or 5 millimeters, that's probably more than 50% or 50%. Okay.
So by the time you reach that stage that you are sort of measuring the depth of this tendon, you've committed one way or the other to the patient that you are probably going to repair.
Oh, I discuss with all my patients.
And is it an idea that all symptomatic partial cuff tears, by the time you reach your scope inside, with nothing else as the cause of or possible cause of pain, should be repaired
Yes.
irrespective of their depth?
Yes, I discuss with all my patients, even the patients that are coming for unless I'm sure 100% it's no tear. I do ultrasound myself to the patient. So sometimes you have queries whether there's a tear or not. Sometimes you are sure there's no tear, but then you can't be 100% sure that you don't miss a small partial tear. So I discuss with all my patients that if I find a tear that needs to be repaired, should I repair it or not? Some patients will say, no, I can't afford being in a sling. You know, if I have to come back for repair afterwards, I'll come. Maybe they wouldn't come, okay? Because we probably, if we operate on all of them, we probably do some of them for nothing, okay? We don't need to do them, some of them. We don't know.
The question is because
We don't know. And I hopefully in a few years' time I'll be able to tell you, because we are collecting the data. And even the ones that were not operating, we're collecting the data, the exact classification, the exact size, and maybe we'll be able to tell you in a few years' time that, you know, Habermeyer B2 you have to operate, with Habermeyer B1 you don't have to operate.
The other thing is that if you have, I mean, that tear happened because the tendon quality was poor. I mean, it wasn't, as Ashish says, all of them are degenerative. And so the tendon quality was poor. So what are we sort of achieving by, you know, kind of, why not just complete the tear and debride the edges and hope for better tendon quality at the edges where you would oppose it again? Why the transtendinous at all?
Because most of these partial tears, the vast majority, there's two kinds. There's the intra-articular ones, which are degenerative, and they start, as we could see, from the joint side, and there are the impingement type that are actually the bursal side. Now the bursal side, if you ask me, if you do decompression, you leave them, they will heal. Unless it's, you know, there's a big flap, I will repair it, you know. but they will heal because you remove the inflicting,
The offending bone.
the offending, yeah. And the bursa will act to come down. The bursa is like the omentum of the shoulder. There's a problem, the bursa goes to try and repair it. So these ones are a different type. The joint side, you need to repair the inner layer because that's where the tear starts to progress. Now, why to destroy the outer layer that gives you a good alignment for the fibers, for the collagen fibers to heal? Why to destroy that? I don't see any reason why to make a full thickness tear. In the old days, when we did it open, I don't know, 20 odd years ago, we had to do it because you couldn't. Actually, we missed most of them because we couldn't see them. If it was intact on the bursal side, you say, oh, there's no tear, you just do a chromoplasty and that's it.
But I thought, and correct me if I'm wrong, the bursal side ones are much more symptomatic and have a more poor prognosis.
I think
more
there's
symptomatic.
a more
We don't know about
symptomatic,
the
but
prognosis part.
yeah.
I think the jury is still out on that. Some of them, like Elman, takes it down and does it completely. Some of us do.
Yeah, but you have to remember that
interventions.
Elman, when he did it, was about 30 years ago or 20 odd years
Yeah,
ago.
but there are others who are doing the
And
same
there were
techniques.
no instruments then. I mean, if I compare what I did, before 2000 and after 2000, when we started to have the instruments, it's completely different. Because we used to treat only the small tears arthroscopically, what we could do with a needle and with a few knee instruments, and now we can do everything. So, you couldn't do that when you didn't have the instruments to do it. So, that's where the difference. But again, I'm not sure whether we should repair them all. I'm not sure whether, and the jury's still out, as she said, about whether to do a complete tear. And we are now actually while I'm here, I hope so some of my fellows are looking at the partial tears that we do this way, because we want to publish it. Not a lot of people are doing it that way. So, hopefully next time I can tell you the results. Yeah,
Just for a clarification of this technique,
yeah.
most of the partial tears are about 1 centimeter proximal teeth insertion. A lot of them. And you leave the remaining bit, distal bit, you leave it as such.
No, I actually, what I do is I take,
You debride the distal bit, or you don't debride it.
I debride the fibrillations just to have because I want to have a good collagen, a good tissue adjacent to the bone. Because if I have this degenerative tissue, again,
So technically you are going to do a tendon to tendon
no,
approximation, or
it's tendon to bone.
Tendon to bone.
Tendon to bone. If there is a crescent like, I want to have the crescent down to the bone. So I take my sutures,
Yes, yes.
proximal to the crescent. So I want to have it down back to the bone.
I just wanted to ask you about the evolution of your practice because the most quoted paper from Reading is the one which said don't have to repair medium size, small size tears in the past. Now, in the recent times, have you changed your practice, and if so, how many of these partial tears are you repairing?
Yeah, I mean, this study was done before 2000, and actually it's a good study because in those days to do a repair means that you actually do an arthroscopy, you do a chromoplasty, and if you have to repair, you have to convert to an open surgery. It was in the 90s, and it was a major difference for a patient whether he's coming for an arthroscopy or coming for open surgery. And in those days, for open surgery, we used to keep the patients overnight or a couple of nights in the hospital. It was a completely different issue. And what we found that in old patients, we didn't have to repair all of them, but 25% of them had to come back for repair. So it's not that, 75% of them you can do with just decompression and leave them, but old patients. If they were younger than 55, then you have to repair them. And even the old ones, 25% of them had to come back for repair. So it's a point of view, and nowadays it's a different point of view, I think.
Because the problem is that the non-shoulder surgeon always says this paper says if you only talk
That they
It's
always
true
say-
about everything in orthopedics.
Yeah, they always say that you should ignore it.
You know,
Well, just
sometimes you write something in certain point and then you change it,
Yeah.
change your mind afterwards. Yeah.
Sure. In my practice, I do exactly like Amit said. So I learned in some papers that the quality of the tissue is bad, and there are some papers in literature with some histological analysis of the tissue, with the borders of the lesion, and they are non-vascularized, and degenerator, and so on. So my tendency has been to remove all these, to complete and to turn this into a full thickness tear and to fix it, and the results are really amazing. But this is not my question. My question is, if you are convinced that this is an articular sided tear, after you finish this lovely construct, will you decompress or will you not?
Oh, I decompress.
Huh?
I decompress before.
Okay.
I do a decompression for a couple of reasons. I do a decompression for a few.
Especially for the audience.
Yeah, I do a decompression for all my cuff tears, because I think the decompression is important. First, to get the space and to be able to do it correctly and to tie the knots correctly without having a lot of bursa in the way, because you always regret if you don't do that. You don't spend a few more minutes to
5 minutes.
to clear.
4 minutes.
Yeah, but to clear it beforehand, because otherwise you struggle afterwards with all the soft tissue there. Second, and this is probably a bit of alchemistry, but I believe that by doing the decompression, why the decompression works? Anyone knows? I mean, what? Maybe. What else?
You're creating space.
Yes.
And
What
even
else?
Even Snyder says that by decompressing, you are bringing a lot of stem cells.
Well, that's what I think. That you have this rain of PRP from
Yes.
from the decompression, and this may help.
Yes.
So I do a decompression for all of them. I think it helps.
Because in such cases, and I do a
Yeah.
lot, I always say to my residents, while the word is discussing, I keep on decompressing. Because I may regret of not decompressing, but I will never regret of decompressing. And
I
four
agree.
minutes, 5 minutes.
I agree. I decompress them, and then I do that. Yeah.
Sorry, is that decompression done for visibility sake or?
For everything. A, visibility. B, if you have a spur, to remove the spur. And C is to have these growth factors, all these goodies coming down as a rain from the top.
Hey, this PRP thing is, I don't know, there's a lot of gimmickry. But no, the decompression has its place, certainly subacromial, acromioplasty, I don't know, but this PRP thing has been pushed by the companies in all directions. And there's not one paper which is double-blind randomized which speaks in favor of PRP.
No. There's the paper from Randelli that shows a trend that it's better, and shows that it's definitely better for pain relief. And I can tell you, that's it. I can tell you, the fellows are looking at it now, and we are planning to do a randomized, double-blind study. So the patient will not know, we will not know what we're giving, because we'll give it with a covered syringe, and we'll see. Hopefully, it's going through the ethics now.
Double-blind studies which emphatically say no difference between PRP and
Depends, again, you have to define what's your PRP, because PRP is not PRP.
I know.
Every PRP is different.
Offer. These are 12 peer-reviewed studies across the board, America, Europe, Nicola, everybody. But it's still out. We don't.
And I can tell you from my experience, at least what I can tell you is the patients are by far less painful. That's.
Thank you very much, Dr. Offer. I think for the sake of time, we'll go on to the next talk. And next talk is going to be given by Dr. Sanjay Trivedi. And the talk is on arthroscopic cuff repair technique and implants, single, double, triple row